All right. Good morning again, all. So Julie Hajewski here, back again this morning. Going to go through our last of the four modules that we are doing. I am going to do this one in full screen today, just because there's a lot of content on these slides. But just a reminder that when you look at them from the off the slideshow version, there's notes on all of these to help you with the content on these slides. So let's get started and dig in. I've got a few more disclaimers, but we'll go through those as we get to those slides. So this final module, Healthcare Provider's Guide to Working with People with Intellectual and Developmental Disabilities. And I think it's important to note, one of the reasons that we developed this module is because one of the things that we kept hearing from healthcare providers and systems is that physicians and nurse practitioners and PAs said, I don't get enough training disability specific. And that's a lot of times we talk about, oh, do you mean you don't know enough stuff about Down syndrome or autism spectrum disorder or what the screening should be for this? And it's, yeah, some of that, but then it's the other stuff, like how do I work with somebody who uses an AAC and how do I work with someone who has sensory processing? And so short of trying to make a module about every disability, that's pretty hard. We really focused on this aspect of what are some of the unique challenges and opportunities of working with individuals with disability, and how can we help healthcare providers feel more comfortable with that part? So at least the technical skills part is more just a learning curve versus getting some of this stuff out of the way. So that's where this module was born from, if you will. Um, so again, just that acknowledgement slide, again, reminding you that all of this work comes down through our federal funding, through our Title V Services Block Grant. And through this license, we can disseminate to you. We can provide these materials to you when we encourage you to utilize them and disseminate them. You can redistribute, adapt, build upon. But again, we just always ask for that attribution to the work that we've done here through the Youth Health Transition Initiative. That's just that pretty slide of me, just kind of my background. Again, 20 years experience now as a nurse practitioner, 15 with UW Health, doing some of this work. On this particular module, I did include a specific acknowledgement. Through my work with the LEND program at the university, I had the amazing help of this LEND graduate. Her name was Sarah Park. This is just a little blurb about her. This is really a passion of hers. And so she was really instrumental in the creation of this module. And I just think it's important to acknowledge all of the work that she helped me put into this. Again, a reminder of that network that the Health Transition Wisconsin is part of a bigger network of providers in the state that work with youth and families with developmental disabilities. So again, a reminder, what is our purpose? That we are ensuring high quality, developmentally appropriate healthcare services, and that those services are really provided in an uninterrupted manner for adolescents as they move into adulthood. Just a reminder, resource for families. Again, probably the most important piece of information I hope everyone takes from this is that the Wisconsin Wayfinder is available for every family with children and youth with special healthcare needs to find resources, whether it's transition related or otherwise. And specifically, they also can contact our children's resource centers, 5 of those throughout the state. We live out of the South Resource Center. You over there in Milwaukee come out of our Southeast Resource Center, and you are able to contact them directly through that number or through Wisconsin Wayfinder. And again, this can be a resource for clinicians and providers as well as direct resource for families. So our objectives today with this module is to learn a little bit about person-first language as it applies to individuals with disabilities. To describe at least 2 strategies that you could utilize as a healthcare provider when interacting with individuals with intellectual and developmental disabilities. And we're actually going to talk about strategies that cover across those 4 different areas related to communication, motor, sensory, and behavioral. Identifying at least 2 possible health-related or environmental sources for challenging behaviors, and identifying at least 2 best practices for serving people with intellectual and developmental disabilities. So start first with just a little bit of disability etiquette. Sometimes this is pretty obvious depending on the group of people that I'm talking to. For others, this is new language. Establishing informed consent is huge. And sometimes we get this a little bit mixed up with um, so there are two realms of informed consent, right? We can be talking about a formal written informed consent. More so, I refer to in this module, I'm really referring to that informed consent of, hi, would it be okay if we talk today about X? Would it be okay with you if I listen to your heart and lungs? That informed consent from the individual to engage, to communicate, to have physical contact. Um, Using multiple means of communication. So, meaning not just my voice, but my body language, my voice, the room, the individuals who come in with me into a room, maybe if I have others with me, um, as well as other things like maybe sometimes I'm actually writing a note or helping someone to communicate with me with an augmentative device. So, lots of different ways to communicate and to keep that in mind. Um, Introducing yourself every time, making sure individuals have time to consume that introduction. And sometimes with some of my individuals with intellectual or developmental disabilities, they'll actually look at my name tag and I'll actually pull my little name tag off on my little stretchy string and hand it to them and say, take a look. Do you want to look at that? Let's talk about it. Right. Um, Asking patients to repeat information back so it's clear that everybody understands the conversation. um, Really, really important one. Speaking directly to an individual with a disability. They are your patient, they are your focus. I may need to get some information from a caregiver or a parent, but that individual is my patient, and that is the primary person I'm communicating with, and making sure that that's very clear to them. Using plain and concrete language. Let's get ready. What does that mean? Let's get up and leave the room together now. Very clear, complex, removes that. It's very concrete versus let's get ready or should we go? Again, can be very confusing. Um, Creating an ongoing consent process. I do this all the time when I care for individuals with disabilities. I just listen to your heart. Now, is it all right if I move my stethoscope to your back? Okay. Um, Starting with person first language, we talked about that. I always give this example. We don't ever do a presentation in healthcare and say, diabetic adults or hypertensive adults. We say adults with hypertension. Why do we say Down's kiddos? Why do we say autism kids, children with autism, child with Down syndrome? Just really remembering that person first language. Um, and so those are just some basics, but those are biggies, right? Like if you take nothing away, start there.
Julie, I just had just a quick comment. So there is a movement within autism or neurodiversity of identity first language. Um, I haven't seen it in the literature regarding people with intellectual or developmental disabilities or like people with disabilities, but I do see a lot in my publishing and presentations. I make note of that I'll use identity first language for this particular movement. So it's always gray. So I'm just curious your thoughts on that.
That's a great point, Gina. And I actually have in the last 2 years have been hearing more that, yes, that very conversation of it's okay to use that identity first in autism specifically. And so that is a little bit challenging for providers and trying to remember which disability is and isn't okay. And so I think that's a great point, simple conversation of how do you like to be identified? Is it okay if I say this, or what do you prefer? So I think that's a great point, Gina, that is an evolution. That pendulum is always swinging with some of those variabilities. But I have heard that specific to autism also in the last 2 years. In general, I still stick with the person first language when we're talking about majority, but I think that's a great point. So thank you for bringing that up.
You're welcome. Thank you. I appreciate your comments too.
I just had one quick comment, and it was a little bit related, but it has to do with the addressing them directly. I know, again, some people with autism, some people with particularly maybe medical trauma, can find it pretty overwhelming. And so, kind of like with asking, person first or, identity first language, I wonder about, how do you prefer to have this conversation go? Who do you want me to ask these questions to? Because I know for myself and my daughter, she very quickly gets overwhelmed if people are directly asking her questions. But we like to convey, she's going to let me do most of the talking, but she feels very free to jump in if I get something wrong or if there's something we want to add. She kind of prefers to be a little bit of a side character. I think it's a little bit less directly overwhelming to her. And I think there are some other folks with autism who might feel that way as well.
I think that's a great point, also, Katie. And I have a young person. I say young, I think she's in her 30s, but a young person that I care for. And the same kind of thing. I will tell you though, I always start my conversation every time I come in the room directly with her. And I say, how are you feeling today? Would you like to talk to me today? Or would it be easier if I talk to mom today and you let me know if we're missing something? And
Yeah,
she
I
will
love that.
usually point to mom. Right. And so I agree, but I still always, I walk into a room and that's my patient until they, yes, give me maybe an indicator that it might be helpful if I engage a caregiver. So great point. Great point. Thank you.
Thank you.
I love the examples of language too, as we're thinking about providing this content for, you know, newer providers. So I appreciate the discussion.
Absolutely. Absolutely. Consent. So big word can have legal implications. Um, and it involves all these legal things. And if you remember, a couple of episodes ago, we talked about, or I guess one episode ago, we talked about supported decision making. So this conversation of consent is just a little bit more generalized, right? And I think we always have to have that caveat is in place of if there is a specific decision making tool in place, like a guardianship or a formal supported decision making or a formal healthcare power of attorney, then yes, those legal entities still apply. And we have to fit this data into how does that fit with that legal tool. In general, remember that capacity is not static. Now, that doesn't mean you have a guardianship in place, you have been determined to be incapacitated, that guardianship stands. But on a day-to-day basis, in a conversation, in the exam room, or in a clinical setting with patients, capacity is not static, right? There are good days, there are bad days, there are days where we might feel able to make a better decision, and other days, like as Katie described, like maybe I'm really sensory overwhelmed and I am shut down today. So capacity may feel and look different on a given day. If you have an intellectual disability, it doesn't mean you are not able to give informed consent. Vice versa. Just because you don't have a guardianship or power of attorney doesn't mean that they can give consent. So it is really a nuance that needs to be assessed and evaluated within the legal tools that have available to you. Like, what does this person have in place? And how are they doing today? How are we going to evaluate this? So, for example, I have someone who is under guardianship. But when they come into my office and I say, is it okay if I listen to touching? They're still giving consent and informed consent. And they have the capacity to give that informed consent for that part of their exam.
Could I make a quick comment about that? I'm sorry.
Yeah,
Um,
no,
I one of the things is you were talking about clear language. I think that's so helpful. And one of the things I think can be a sticky spot is where does the person kind of have a choice and where don't they? And so I think sometimes what works well in that case is sort of declarative language to open a conversation. I'd like to listen to your heart and lungs and sort of see where that goes, because I think sometimes if we say, "Is it all right?" and then they say no, it sets up this really tricky situation where, shoot, I wish I'd phrased that differently because I don't wanna override your no, but we kind of need that information. So I just wondered if you had any tips for people or thoughts on that.
that's a really great point. And actually, it's one of those nuances of practice that's hard to capture. But I literally do as you have just said. So if I say, is it okay today if I do this? If they say no, I haven't asked a question that I can't accept no as an answer to.
That's really good. I love that. Yeah, because that's, I
Okay.
think, so important.
Yep. So if they say no to something that I have asked if it is okay, I, with rare exception, will do my darndest to honor that because I want to honor that consent. And so I did. I had somebody the other day and they said, no, I don't want to get up on the exam table. They didn't use all those words. They said no.
Sure.
And I said, okay, we can skip it today. And the caregiver said, oh, no, 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 we got to do this. And I said, actually, I gave them a choice and they said no, and it's okay today. I don't need that information. So if it's something that I need, I will pose it differently.
I
I will
love that.
say, we need to do this today. It's important. How would you like to do that? Would you like me to listen to your heart here on the chair or up there on that table? Or do you want to stay standing over here where you're at and I'll walk up by you and do it? Right. So I try to give that choice where I can, even with that thing that is necessary to do.
That's great. I really love that.
Yeah. Okay. All right. Oh, there we go. So when this approach that we're going to look at today, when Sarah and I did a lot of this work together, we're like, how do we, how do you eat an elephant? One forkful at a time, right? As they say. So we really tried to break this down. What are these strategies? And so we broke them down kind of into these four categories: communication, sensory, motor, and behavioral. You could do this a lot of different ways. This is just the way that we chose to kind of focus them because it really kind of made the best sense with the materials that we were putting together. So first, we're going to look a little bit at communication. Building rapport is huge. And so we know that when we can build rapport, people are more comfortable, they're less guarded, they're more honest, and can have some genuine communication that can really identify things that are concerning for them that we need to make sure we're addressing. Because if someone walks through the door, and it doesn't matter if this is one of my special needs youth or if this is an average person, if they walk through the door and they don't have the opportunity to tell me what's most important to them that day, they're going to be dissatisfied with that interaction, right? So making time to sit down. Now, this is a bigger thing in hospital medicine when you might walk in the door, talk to a patient for a second and walk back out. It's not so hard in my clinic setting. I walk in, I sit down, but again, making sure that you are meeting people at the same level, looking like you have time to listen to them by sitting down and taking a moment. If you remember from our first module, we talked about youth spending time alone with a healthcare provider at every visit, just a reinforcement of that helps build rapport and trust in that provider for youth also. And then asking questions about their lives that build rapport that also provide you with information or data that might help you identify health practice and habits. How are things going with Special Olympics? How did it go with that final basketball championship game? Were you able to run all the way through it, or did your knees bother that day? Um, One of them is exploring social relationships with some of my adults with disabilities and making sure that those social relationships are safe for them. And so I will ask, tell me more. You said you had a new girlfriend. Tell me about her. Did you go on date? You went to the movies. That's awesome. Did you hold her hand? Helps me explore through rapport building. How much, guidance and assessment do I need to do maybe about some other social and health practices that could impact my care? Some of the basics, choosing appropriate language. There's that concrete language again. Avoiding jargon, and I'm really bad at that in my day to day, and so I really kind of have to think about that and focus on that. Sometimes when I talk to individuals with intellectual disabilities, because jargon and common phrases can really be confusing. Simple sentences, tone and volume is normal and appropriate. It's not loud. It's not, you know, talking babyish. Um, Using multiple modalities. So I might say, how many times did that happen? But I also am going to say, did that happen once or twice or a whole bunch? Right. So we have a visual and auditory, different ways to make sure that we're communicating. Using visual or audio aids. I keep anatomy books, like a big one that's like 30 inches tall, and I might flip it open and say, let me show you where we're talking about. Offering people to write things down, or more commonly in my work, because I have the electronic health record with a written after visit summary, I will actually say, let's go in and write that down together so you have that information later. And we'll go into their after visit summary and I will type it up. I will read it out loud while I type it and say, does that make sense? So you have that information for later. And asking someone if they have an AAC device to communicate. I'm going to talk just a little bit more about that in a moment. So digging in a little bit, thinking about people with intellectual and developmental disabilities, many times will have more receptive language than they do expressive language. What does that mean? I have a kiddo who is 14 with Down syndrome. He is essentially nonverbal for all intents and purposes to forward public spaces, right? He 100% understands everything you say to him. So my son may say thank you with a sign, and someone will look at me and say, how do I say you're welcome in sign language? And I said, you don't need to, you just did. Because he 100% understands receptively, he understands everything. Expressively, he is very limited. So thinking about that in your communication, reflecting and summarizing content and asking clarifying questions. Did that make sense? Did you see that spot on that picture where I pointed for you that that's happening? Do you understand or do you have questions? Showing empathy, redirecting. I have one patient who I'll answer a question. I will ask a question and they will tell me about something else that happened in their day. And I will say, that sounds awesome. But this is really important to me today. I know it's boring to you, but can you tell me, did you poop this morning? Right? Some of those kinds of things. Rephrasing as appropriate. If you've asked the question several times in the same way with a blank stare for a response, you need to ask your question differently. Okay, figure out a different way. And that sometimes is engaging a caregiver to say, what word do you use at home for this? Or do you understand my question? Because I think I'm missing something, so maybe it's not happening. Help me understand how I can get this information in a better way. Giving people enough time to articulate. And that means asking a question and waiting for them to have the chance to formulate an answer. And being okay with that silence for a moment, which can be really hard when your schedule is packed or you have lots of people to take care of. Asking people simple things. How do you say yes and no? My son has multiple ways to say yes and no. One of them is blinking. One blink is yes, two blinks is no. One of them is a X in the air for a no and a check mark for yes. Once I tell someone that, they're like, oh, got it. Otherwise, he's just making motions and we don't know what they are. So asking someone simple things like, how do you say yes and no? Show me how you like to communicate. How can I make things go smoother? Would you rather say answers to me or would you like to use one of those other ways to tell me? How much time do you need before I repeat a question? I've worked with individuals with AAC devices where they need quite a bit of time to formulate a question. And I will say to them, is it okay if I go on and you stop me when you have an answer, or would you like me to wait? And then honor that answer. Displaying and demonstrating exam techniques, I do this all the time. Remember I said I needed to listen to your heart today? Here is my stethoscope. I want you to feel it first. And here's where I'm going to put it on your body. I'm going to show you on me first. Now I'm going to do it on you. Lots of I statements. I want you to be able to communicate with me and feel comfortable. How can we do that together? Or what can I do today? Keeping with those I statements and making sure that you're communicating clearly. Recognizing self-soothing strategies and ask if it's helping. So sometimes I see individuals who may have sensory input strategies that involve fidgeting or tapping or pulling or tugging on something. And I will see a caregiver or a family member say, hey, stop that for a minute while they're here. And I'll go, oh, please don't. That's okay. They're processing other energy over there so they can focus on me also today. And I'm okay with that, right? Now, if that self-soothing strategy is extremely disruptive or self-injurious, that's a different conversation, right? But I always recognize those two things. I'm like, I see that you're a fidgeter or a tapper, or you need this. That's okay. You keep doing that. Is it all right if I keep talking while you do that? Seems to work very well for a lot of people if you give them that sensory output. Modeling things, I do, we do, you do, we've all heard that one. Providing examples. Do you remember when? And I do that a lot. Remember last time when you were here, I listened to your heart. I used my stethoscope, I put it here and it doesn't hurt. I'm going to do that again today. Asking, turn taking. I think this is a healthy behavior. I think drinking milk once a day and having water the rest of the day is a healthy behavior for an adult. What do you think? Right? Scaffolding, breaking information, directions, and things down into chunks. Remember when I listened to your heart with my stethoscope? Today, I would like to listen to your lungs also. So I'm going to move it to your back. So we've scaffolded, we've learned this skill and it went okay. Let's do this next step. We can do that with any health behavior. We can do that with any activity or behavior, but I really like to use it in the inpatient and clinical setting to help kind of build those skills and comfort with doing health-related tasks. Alternative and augmentative communication devices, or AADs, speech generating devices. At our house, it's called the talker. So essentially, they're electronic devices. Through button pushing, they're able to construct a verbal, whether it's a sentence or a concept or an idea, and then hit an output button, and it generates speech asking for a request. And sometimes at our house, it's more yes, no, watch this. It's very short phrases. I've interacted with individuals in which they maybe come to the office and have pre-created phrases developed for me because there's things they want to make sure they talk to me about. I have worked with a friend who has their entire order for McDonald's on one button, Culver's on another button, and their favorite Mexican restaurant on a different button. So it runs the gamut on how that device is utilized. Give them the opportunity to use that device. You don't have to do all of the talking. Let them know, though, if you don't understand what they have said. It's okay to ask several times as long as you're respectful in that. And as I mentioned earlier, I will sometimes say, I can see you're working on generating a response and I'm looking forward to it. Is it okay if I keep talking about a couple of other things, or would you like me to wait first? And individuals will tell you what they're comfortable with. And again, if you're like, I'm not sure what we're talking about, tell me again so I can understand. That's okay. Versus I have worked with someone who said, I don't know what you're saying. I'm going to move on. That's different. It's not okay. Allowing for extra time, it does take more time. And if possible, finding a quiet environment can be helpful. If you're in a very loud environment, working with a speech generating device with an individual can be very frustrating for all involved because it can be difficult to hear and difficult for them to compose in a really loud or busy environment. Think about that device as part of their body. Don't ask them how it works. Now, if you get to know someone really well and are having some conversation, absolutely, they often are interested and willing to engage in that. But it is their voice. You wouldn't touch someone's mouth while they're talking. Don't touch their device while they're talking. Now, if they invite you, like my son, sometimes my son will grab my hand and pull it over and push a button. Or I will say, do you forget where that button is? Do you want me to show you? And he will say yes. And then I will take it and I will show him where that button is at for what he wants to say. But otherwise, that is their voice and treat it as such. Yes, no questions can be easier, but please make sure some open-ended, right? Are you okay with this today is a yes, no. Is there anything else you wanted to tell me today is your open-ended version of that. Let them finish what they're saying, ask clarifying questions. Make sure you repeat back what you heard so that everybody is on the same page for that message, that it was received and it was clear. Body language. Affirm with both verbal and nonverbal. You can say, I hear you. You can also say, I can see that you're feeling frustrated right now. I see that in this. Is that frustration? Okay, tell me more about that and how can I help you feel better? Again, talking to that person, but like you said, Katie, unless someone has said, hey, I want to transfer that conversation to my mom because this is really overwhelming today, that's okay. But I will still say, hey, Katie, is there anything else you wanted to tell me today? Mom got it all? Great. Okay. Always staying in line of vision, always staying with hands visible. Those are non-confrontational things so that people feel safer and they know what you're doing and where you're going. Um, Body language, levels in empathy squat, right? Like bring yourself to that person's level, but also making sure that in that motion, stand before you lean before you squat, squat before you kneel before you sit. Like you're not just throwing yourself onto a chair and turning around. I really like intentionally sit down, quietly turn. Yeah, not blocking exit. Um, if I have someone who is clearly struggling with the environment in my office, I am careful that they feel like they're safe, that they have an avenue to exit. I also make sure that I do in case they do become extremely overstimulated or agitated. Practicing that social distancing, especially my individuals with processing disorders, autism disorder, I will say, I'd like to get closer to you right now. Are you okay with that? Before I do that. Again, that consent part. Moving into functional strategies. This is a really important one just for basic physical disabilities, and I don't think anybody teaches it or talks about it. If I'm going to bring someone into the clinic and they live in a wheelchair during the day, and I need to look at a sore on their sacral area of their butt, how are we going to do that in the clinic? Okay. So learning about how someone transfers, making sure that we have things available, making sure, hey, asking them to bring along their tools to transfer or modify an exam to a wheelchair. If you look at that second picture down there with that power chair that tilts, I want you to know I have done a pelvic exam just like that. It can be done. Is it challenging? Absolutely, but it can be done. So just thinking about how are we going to physically achieve things when individuals may have physical disability that limit our ability to assess them in the healthcare setting. Some of these are really in depth. They're very self-explanatory. They're things that we often are familiar with. Just remembering that different disabilities sometimes have different muscle tones associated with them. Spasticity is a big one that you'll see in cerebral palsy and some of our other physical disabilities. I have been kicked and hit by many a peer person with spasticity, and they are horrified when it happens because they didn't control that movement. And I am always very quick to oop, that was my fault. I did not give your arm enough time to know that I was coming closer. Don't worry about it. Okay. Deep pressure stimulation. This is something that, especially in our autism community, we're aware of. We're seeing growing awareness of it, even by weighted blankets at Target now. It's the same concept that some individuals do better with deep pressure stimulation. I have a kiddo when he gets completely dysregulated and overwhelmed. If I can get him in a big bear hug for 10 seconds, oftentimes we can reset that sensory dysfunction that's happening and we can start over and do a lot better. So just really depends on the person. Not all individuals want this deep stimulation, but it sometimes can be helpful for some. Less invasive if touch comes from extremities in. I never start with an abdominal exam. They always start with something more simple. Can I look at your hands? Would it be okay if I look in your ear, heart, lungs, then move on to belly? One that I'm always really, really careful with, thyroid exams. If you are trained in thyroid exams, oftentimes those come from behind with two hands onto the front of the neck. Always asking permission before you walk behind someone and put your hands around their neck, because we have many people, disability or not, who have had trauma incident, childhood or adult trauma, and that can be very, very triggering for them. Some motor strategies for positioning. A lot of people aren't aware that there are many, many tools out there Those photos on the right are actually of an operating room. We use those type of vacuum packed bags for the operating room for any individual who is been put to sleep and has no muscle tone, but they can be especially helpful for individuals for positioning if they have a physical disability in a clinic setting, trying to do some sort of exam or something specific. The ones on the left are just more for comfort, right? When we talk about individuals with physical differences that can sometimes make some of our standard equipment uncomfortable or impossible even, right? Moving into some functional strategies related to sensory. A lot of different variabilities of sensory input and output differences in our individuals with disabilities, as well as neurotypical individuals. So we know there is differences in our nervous system throughout many people. There's a lot that you could cover here. There's a lot I'm not going to cover. These are just some really basic things for individuals who don't have a lot of familiarity with it. Um, Sensory defensiveness is a big thing and it is real. And it is that challenging behavior, that emotional distress that happens when there is excessive input. And it is often manifested as a fight or flight response. And if you can understand that at the get-go and realize that this person is not a behavioral challenge or doesn't like you, if you can understand that that fight or flight is coming from sensory input challenges, it can be life-changing to your practice for taking care of these individuals. So again, a lot of talk already about touch and consent. I won't go through that again.
Like you mentioned,
Remember,
oops,
oh,
sorry,
go
I was
ahead.
just gonna
No, please.
reaffirm what you were saying, Julie, and when you talked about kind of the apologetic nature on behalf of the caregivers, like it's so soothing when people recognize that for what it is versus, I've had to really reorient myself into I really am here for my daughter's comfort, not the healthcare provider's comfort. Not that I don't care, I do, but sometimes as a nurse, it can be tempting to overly identify and, like you said, kind of put a damper on whether it's self-soothing behaviors or things like that. And one of my daughter's coping devices is swearing, so it's very challenging to know where to draw the line there. But it is so helpful to have providers realize, like, really the number one rule is just don't take things personally. And it sounds so simple, but I don't think it's emphasized. I think it's underappreciated how much kind of song and dance usually goes into a visit where we're kind of a lot of social nicety that this population doesn't necessarily have the wherewithal to always engage in. And so I just really appreciate you saying that not taking it personally, because in addition to building the, rapport with the patient, it also lets any caregivers sort of focus on what they're really there to do versus trying to smooth over, something that wasn't personal.
Absolutely, absolutely. And I have had that conversation with many a provider, and it's an interesting concept. And like I said, if you get nothing out of this part of it other than it isn't personal, that's great. Right, I've done my job.
Absolutely, that's
So
wonderful.
yeah. I think it is important, as we previously have kind of I touched on, remember that there may be previous trauma or abuse or neglect that stimulates some of that sensory defensiveness. And so recognizing that there may be very deeply ingrained trauma that 3 or 4 visits a year to your office are not going to overcome. Okay, so figuring out how we work together to take good care of someone is your job as the healthcare provider. Um, some of the things that can be utilized to reduce sensory distress, there are many. And if you work with families with an individual with sensory challenges, oftentimes they know about many of these, but it's always good to, I will often say, okay, next time I'd really like to be able to do X with your daughter, Katie. Are you guys doing this? Are you familiar with this? Have you ever seen this? What about this tool? When my son needed to have molds made for hearing aids, we spent days watching YouTube videos of kids going to the audiologist office and getting that putty injected into their ear canal and then taking it out and looking at it. And I did not think my son would ever be able to do it. And he does it because all we did was watch YouTube videos. Like he'd have his YouTube kids, and I'd be like, "Oh, look at this one," and I'd slide in a YouTube video of a kiddo getting ear molds made. So they really can be effective depending on the individual. Others want to sit and look at a storybook, like a social story where they can flip it, or they want to look at a chart where it's a step-by-step process. So we maybe can check those off as we go. So that's one thing, thinking about those social stories and video modeling for what's going to happen that day. Getting to know someone so you know what their triggers are. That just takes time and rapport for a caregiver. Getting rid of things in that room that you don't need if you know they're going to be a trigger for someone. The day that the University of Wisconsin system decided to remove everything from underneath the sink in the exam room because it was an infection control risk was the day that I, as a mom of a disabled kid, sang hallelujah. Because my kid loves nothing more than to open and close those doors, and he'll take everything out of that cabinet. And they took everything out of the cabinets, and there's nothing to take out anymore, and I love it. So those kinds of things, if you know an individual. Reducing stimulation in the environment if that is a challenge for that individual. If they hate bright lights, then turn half the lights in the room off. If they hate overhead noise, can you eliminate it? It's really hard in my clinic because we have these speakers that do overhead speakers, but I actually, outside my exam rooms, took a chair, climbed up on the ceiling, and I've turned my speakers off. Don't tell my clinic manager. Because they're really disruptive. And if you have sensory input, they're really disruptive. Watching my position relative to a person when I'm caring for them, watching my tone of voice, watching where my hands are, especially if I have someone who has known trauma and healthcare trauma and they're very on edge or sensory defensive when they're in my environment. There are a lot of slides here about spotting trauma and abuse. Depending on your application for this slide, you may hide some of these. This was really an area that was near and dear to Sarah, who helped me create this, and is really something that she is interested and focused on. So there are lots of things here where you may say, I'm going to hide part of these slides, but we'll go through them briefly. We know that abuse and exploitation for individuals with developmental disabilities is really high. 4 to 10 times more likely to be abused than a peer without disability, often for longer periods of time. That's less likely to access the justice system because many of them don't have the means to independently do that. And oftentimes their abuse is much more likely to be from a caregiver or someone they know and be repeated over long periods of time. They're more likely to remain in that abusive situation because oftentimes they don't understand that that is an abusive situation, or they're not able to verbalize or process that as an abusive situation. And children with disabilities have a higher risk of being abused or neglected. Many, many different signs of trauma. In a neurotypical individual, we expect them to come to us and say, someone hit me and I have a bruise on my face. That is not how it plays out often with our individuals with intellectual and developmental disabilities. With physical abuse, it may be some of those other non-specific signs like developing diarrhea or constipation, unexplained weight gain or weight loss. For goodness sakes, indications of a sexually transmitted infection. We all know that one. If we have a developmentally disabled person who shows up with chlamydia, boy, we need to be prompting some further investigation into that situation. But can be as simple as changes in monthly menstruation, because we know for females, significant stress or emotional stress can change the menstrual cycle. Behavioral things. When youth and individuals start to replicate assaultive acts on themselves, we need to ask questions about what's happening. Is there a place where this is happening? Or replicating it on others. Self-harm and mutilation, increased sexualized conduct, regression from skills already mastered. Sometimes this can be a challenge, though, and I can tell you, as the parent of a 14-year-old teenage boy, what part of this is puberty? When do I need to evaluate if someone is, it is very challenging. And those are questions that, we have to just talk to families about, kind of that longitudinal paying attention. Are these things? So for example, I have a kiddo who now, when he sees people on a television screen in a movie kissing, For several days, he is trying to kiss his mom like he is that person in the movie, right? And so we have to talk about those boundaries. That's pretty normal development. But I'm very, very conscious of, is that changing, evolving? Is there something more there that I need to pay attention to?
When
But
I
that's a
took
really,
my mandatory
yeah,
reporter training, I remember just cringing because I'm like, this is all, par for the course at my house, and I can promise you that nobody's being abused. But like you said, it's such a fine line. And the other thing, and maybe you get to this, but I feel like with abuse, the important thing to point to make is, because in particular they are so vulnerable to abuse, that's why the consent is so important. That's why the respecting no is so important. And I know I used to work in labor and delivery, and we would talk about how some of the language we would use was similar to language abusers would use. You need to lay still, you need to hold still, like those types of things. And
yes,
so I think awareness of how healthcare can either, be helpful or harmful in terms of sending people the kinds of messages about agency over their body and those types of things. Because I think we have the ability to do a lot of good, but we also have the ability to unwittingly do a lot of harm.
absolutely. Absolutely.
Thank
And
you
it
for
is a fine
tolerating
line.
all my interruptions,
Oh,
Julie. You're a
no, no
good
worries.
sport, and I just love
Yeah,
everything that you're saying.
good, good. Yeah. Signs of trauma emotionally. Again, a nice list there, but a wide variety. And again, needs to be applied to every individual person and kiddo. What's their norm, and is this different for them? And do I need to think about or investigate more into this behavior? Oh, I just lost my ability to move my slides. Hold on. There it goes. Sexual abuse. So again, individuals with cognitive disabilities maybe won't show that in the way that we have them. But again, are any of those other things happening that we just went through and looked at, from social, emotional, and behavioral changes, that might indicate that we need to look into this further? Again, often do not disclose. Either they don't have the accessibility to disclose, or they don't have the emotional or social language to disclose. So again, remembering to look for that changes in mood, conduct, communication, again, changes that are different for them from their comparative norm. Emotional trauma comes in many different ways. Um, we can see depression, withdrawal, anxiety, fear, reenactment, very similar things, right? The classic emotional trauma for an individual who is verbally abused is, I'm having a conversation with them and a loud crash, bang, something happens in the hallway and they cower. Ask questions, right? Tell me about that response. It looks like that really bugged you. So what can we do? A lot of things we've talked about. I won't read through this, but again, thinking about what is the norm for this person and when should we investigate more. Lots of tools and resources. I have a couple of resource pages coming up here shortly to explore that. The next one, there we go. And so some really great toolkits for those who have further interest, and those links there go directly to them. So please explore this PDF later and grab those if you're interested in exploring those a little bit further. We are running a little bit tight on time just because we've been having some great conversations. It's about 9:53 right now. How is everyone's schedule? Do we need to be prompt at 10? We do. Okay. Julie's going to speed it on up. Behavioral. Um, Remember, behavioral challenges manifest physically in many individuals with cognitive disabilities or intellectual disabilities. So me hitting you at a visit because I don't want you to listen to my heart is not a behavioral challenge. Okay. It is likely more so related to something physical or trauma related, but could be related to a very specific problem. So just remember, something like an ear infection may present as behavioral challenges, and we need to have our mind open to evaluating for those other things. Constipation could result in someone sitting in the bathroom digging at their rectum. That is not a behavioral problem. That may be a, I don't feel good, I can't poop and I need help. So being open to that and thinking that about just not assuming that a behavior is a behavior. All behavior is communication, and we've probably all heard that many times. Pain and distress is often unrecognized in individuals with intellectual and developmental disabilities. I can't tell you how many times I've taken a kid to the ER and said, I know he looks fine. This is not his norm. It is my job as his parent to tell you there is something going on. I need your help to investigate it. Okay. So I encourage a healthcare provider to acknowledge that caregiver input, to acknowledge that even though this might look okay to me as a healthcare provider, is this the norm for this individual? And those non-specific changes in behavior may be the only indicators you have before significant medical emergency occurs. Lots of good information here about behavior stages. Many of us are familiar with this. Just remember that when we get into this escalated or crisis behavior, stop talking, stop giving input, step back, make sure there are ways and accesses for everyone to comfortably leave the space or feel safe, and don't re-engage until they're ready, and be prepared to take that time for them to be ready to re-engage with you. That's this whole slide in 3 seconds. Again, we talked a lot about how to de-escalate, how to prevent some of these behaviors. Tips for reducing challenging behaviors. That transition is huge. You're doing really great. We're going to be done in 2 minutes. Can you do 2 more minutes for me? Awesome. When we're done with that, we get to leave this room, okay? Goes a long ways. So best practices, making sure we have shared plan of care, making sure we're doing mental health referrals when they're appropriate, making sure we're doing preventative health maintenance, not just putting out fires every day. Healthy People 2020, that healthy behaviors, if we tell people and remind people from the healthcare setting to have good and healthy behaviors, it can be impactful. More impactful sometimes than mom, dad, or other caregivers. Mental health referrals when they're appropriate. I won't belabor that. Using electronic health record to your advantage. I try to do this all the time. If I have a kiddo with Down syndrome who's nonverbal, I'm going to put Down syndrome on their electronic health record as a diagnosis. I'm going to go under the overview on HealthLink, and I'm going to put in a couple of things. Mom does this, says yes or no this way, has troubles with this. Make sure you don't touch his belly until you talk to him and he's comfortable, right? Putting those in the notes in the electronic health record for the next person to be able to click on it and go, oh, this is like a treasure trove of how to have a good first visit with this kiddo. Okay. If there's a history of sexual abuse and you have some details, this is not to exploit it. It's to be clear. Abused, age 6, respite caregiver, no longer uses any respite services. Parents have no relief. That's huge, right? Versus abused as child. What does that mean? Help me understand how that might impact care today. Interdisciplinary healthcare, making sure everybody on that team is part of the team taking care of that individual. Shared plan of care. This slide came from one of our family advocates who worked through our LEND program, and it was a great list. And so is it evidence-based? Not directly, but it's really important. And I think for myself, I can reaffirm it. I suspect Katie will also welcome that child and that individual directly, say their name, say hello. Please tell a parent, a caregiver, a loved one that they're doing a really good job, because I see she has her favorite stickers on her wheelchair. Where did you find those stickers? Whatever it is, taking time to acknowledge that caregiving is a hard job and they're doing a good job. Find something individual, something personal. Hey, I see you have a Jack Skellington sticker on your wheelchair. I love that movie. Goes a long ways. Take a minute to ask how everybody else is doing. Mom, I know you've had some health challenges, and that might impact what you're doing here today. How are you doing? Okay. Now, sometimes that can be a can of worms. Be careful. You might really get how mom is doing, and you need to be prepared to have time for that. And then every time, and I do this for every person, whether they're one of my individuals with a disability or not, Is there anything else I can do for you today? Is there anything else that you needed? Um, and if it's a big topic, ooh, you know what? We're not going to do that today, but can I make sure we have a plan that we're going to come back and do that next time? When do you want to come back and let's tackle that? Ooh, sorry, flip past that. Lots of references here. Lots of good stuff here. Those toolkits are referenced here again today. This is how you get a hold of us or get back to me through Tim. And a simple thank you. So that is that module.
It's fantastic.
Questions, overview.
Right. So I'm going to give you an option. I don't know, Lynn, are you able to hang for a few more minutes if I make you host? No, you are not able to either. Okay, then really quick questions or write them down and we'll get to them in August.
Yeah. Anything burning, otherwise happy to address those offline in the next few weeks. Oh, Michelle, I'm glad to see that you were able to join us for part of it. Sorry, my screen was
Yes.
limited.
No, I want to say hi before. Nice to see you all. Thank
You
you.
too, Lynn. I'm happy to hear you're going to be part of this process. So thanks for joining. Sorry, I meant Michelle. I said Lynn. I'm looking at Michelle, Lynn, and Lynn. Too many names. All right, very good.